Anthony. And Anthony will not only, there's the reminder, by the way, that you're being recorded. And this is just to, if you don't want anyone to hear you talk or to see your face, you can turn off your video if you want, whatever you're comfortable with. But this is, like we talk about, truly informed consent. So what we wanted to talk about today, which is the last of our 4 sessions where we're talking specifically about safety planning, is to focus on the latter aspects of safety planning, which is lethal means access counseling, and to look at how to use motivational interviewing and solution-focused therapy to enhance that, why lethal means access counseling is so important, why it must be paired with safety planning, why safety planning needs to be delivered in a particular fashion to be effective, the advantages of safety planning over the typical assess and refer model that we've talked about, and reinforcing all we've talked about earlier about how to prevent suicide. So we're going to focus on the rationale for lethal means counseling. And as a heads up, all the information that I'm giving you about the epidemiology and the overall perspective of suicidality, how people experience it, opportunities to prevent death, is some of the information that I hope that you can utilize when you actually meet with the folks that we're trying to help, to give them the context and the information, and to draw the parallels between all the personal, idiosyncratic, very specific information that they're giving you about their own experience and how to relate this to all these general trends. Then we'll talk about that stepwise process of what to do with safety planning and a process for lethal means counseling that's also stepwise and evidence-based, called CALM, C-A-L-M, Counseling to Access to Lethal Means. Now, we don't have time to go into all the aspects of CALM training. A CALM training session is typically 4 to 8 hours at the minimum, but we'll give you all the key objectives and the main techniques in CALM, and give you the information how to link up. You can get the training online. And also, again, if a big chunk of you are interested, we can arrange for you to have that training. So we're going to go into that. And then the hope is that you can use a case example from your own experience to utilize this to create a safety plan that incorporates lethal means access counseling for the people that you see. We're not going to actually do a case example together today, but the hope is that you'll take this home with you. And like we've talked about all the time, what happens outside the office and in the real world is much more important than what happens in any office. And that's true of training as well as therapy. So feel free, like Anthony said, at any point in time to raise questions in the chat. I'll monitor it constantly. And if you feel comfortable unmuting yourself and asking questions, that's great. If you'd prefer to keep it totally anonymous and not worry about the chat room, you'll have your my email. And a lot of you have contacted me by email offline to ask questions or to further our conversation. This is all to set the stage for the following 4 weeks. We're going to be meeting together to talk about seeking safety, which was one of the first evidence-based practices that addresses co-occurring substance use and misuse and substance use disorders, as well as serious mental illness and severe mental illness, including severe stress disorders like post-traumatic stress disorder. The bulk of seeking safety, like it sounds, is actually safety planning. And so in our 9th week together, we're going to put it all together. But really, throughout the next 5 weeks, I'm constantly going to refer to safety planning as we talk about seeking safety. So nothing to disclose, like you know. And I'm going to hit the highlights of what we've talked about the last 3 weeks. And this is all the kind of rationale for why we feel so strongly about how safety planning should be done anytime we see somebody who's at risk for self-harm, not just narrowly at risk for consciously, deliberately, planfully ending their own life, being suicidal, but there's a lot of people who engage in risky behavior that could result in serious injury, if not death. We want to prevent that. And so the core of prevention is early identification and treatment, early intervention, good follow-up care, the training of all of us in the techniques that work, viewing every intervention that we have, actually any encounter that we have with anybody, as always offering them something that's uniquely targeted to their unique needs and selfhood, and that we don't discriminate and separate, much less divide, triage, screening, assessment, disposition planning, referral, introduction to a clinic or to a practice, history taking, and intervention. In other words, every time we meet somebody, we want to intervene. We want to offer them something. And we want to spend the most time giving them the tools that they need to function better after they see us. As we've talked about in these last couple of weeks, we cannot prevent suicidality. We cannot avoid people encountering difficult, traumatic, abusive, challenging situations that make it hard for them in the moment to cope, that make them feel at that moment powerless, helpless, hopeless in the situation. But we can prevent death when they feel that way. And that is by this early identification and treatment, training, restricting access to lethal means, which means that even if in the moment they feel that there is no answer except the ultimate escape from the suffering that they're experiencing by killing themselves, if what is at hand to them, what's readily accessible to them, is something that will not kill them, they won't die. And we know that suicidality is rarely constant, chronic, and intense. Most often it's sporadic, intermittent, situation dependent, contextual, and brief. That for a lot of people, like we talked about, between the event and the impulse to hurt yourself and the intent is a minute or two. And between the decision and the intent and doing something about it, making a life-threatening attempt, can be as little as 5 minutes and rarely lasts longer than a few hours, and very rarely intensifies and builds over the course of the day. So that means that in those few minutes or few hours, if you don't have a loaded gun handy, even if you attempt an overdose, less than 2% of the time, an overdose results in your death. Less than 1% of the time, cutting yourself results in your death. So if you don't have a loaded gun, where 95% of the time that attempt results in your death, you won't die. And since that intense desire to escape a dire situation, that intense desire to end your own life willfully, deliberately, consciously, fades within minutes or hours, that means that we save a life if we can prevent suicide in that moment. And the majority of people who make a life-threatening suicide attempt not only do not kill themselves thereafter with another attempt, but also much less frequently make an attempt at all. At all. So if we can intervene in that moment, we might save a life and prevent future suicidality for the rest of that person's life. Certainly reduce it, certainly minimize it. But we need to do safety planning in the way that it is effective. And that is the approach that we've talked about before that I'll underscore today. So this information is really important to give not just to all of us, but to the people that we see and their supports, their family, their friends, their community. That suicidality is often driven by external events, typically interpersonal conflict and disappointment and abandonment and rejection, but other circumstances too, overtly traumatic and abusive circumstances, certainly. One of the biggest stimulants for suicide is witnessing the murder or the suicide of another person, traumatic grief. So looking at that, it's really important. And this other piece is really important too. So they're preventable. Most do not, but this fact that I always like to cite, which is that in surveys of Americans all over the country of all sorts of different backgrounds, all sorts of different geographic locations, socioeconomic status, resourced and under-resourced communities, rural, remote, frontier, and urban, all the rest of it. The vast, vast majority are not hopeless about preventing suicide. The vast majority, that same group, 94% in some studies, want to do something about it. So the idea that there's no one who cares, no one who supports, no resources in any community is not the case. So what we want to do is capitalize on that goodwill, capitalize on that caring, and give all the supports the tools that will help them help others. So we've talked about this at length, but I want to underscore it. Our typical practice is what's called the assess and refer model, not safety planning. We've talked about when we first met 4 weeks ago about how limited our risk assessment is. First of all, we focus on the time when suicidality is most prominent. We talk about past history of suicidality, suicide attempts, hospitalization, mental challenges, substance abuse challenges, dysfunction, disorder, deficits. We never talk about that person. We don't talk about their strengths. We don't talk about their ability to cope, their self-management. We don't look into their natural supports. We don't look into their community and their households as far as, are they supportive and caring and kind and generous? Or are they traumatizing, chaotic, neglectful, abusive, which informs their life? We also look narrowly at, are they, quote, clinically suicidal, meaning do they have a conscious, deliberate, planful intent to end their life, to end their suffering, as opposed to that they engage in risky practices which are ultimately self-destructive and lead to their death, not consciously or willfully, but can. Or are they in such a horrific environment that seeking safety is an impossibility for them? They're always in a dangerous situation. We don't assess any of that. Furthermore, we take people who feel hopeless and worthless and helpless. And in our practice, essentially, because it's totally prescriptive, directive, authoritarian, we further that sense of lack of self-compassion. We further that sense of a loss of agency. We also either overtly or indirectly let them know that we're the experts on them, not them, and that we teach them what we think they lack and what they need. They don't teach us what speaks to them and what's helpful to them. So there's limits in the assessment in all the ways I've talked about, and in the way the assessment is delivered. It's not collaborative, transparent, open, respectful, co-created. Decision-making is done by us. It's not shared, much less directed by them. It's not person-centered or human being-centered. It's symptoms and syndrome and sign and disorder and deficit-centered. So that's a problem with assessment. And now we talk about referral. Oftentimes the referral is either non-existent. We all know situations where people go to emergency rooms, urgent care, and they say, you don't meet criteria for hospital, go home. And here's a hotline. Here's an 800 number you can call. That's it. That's all they get. Certainly, again, it's not uniquely tailored to their unique needs, their beliefs, their understandings, their community, their culture, their spirituality, none of that. We don't even check to see if it's accessible. So we might give them a phone number to call for a clinic that's 60 miles away, and they have no transportation, and they have no way of paying for it. And the clinic has a 6-month waiting list. So no wonder, if we look at the statistics, that very few follow up even once, and the people who follow up for a month or two drop out almost instantly. Now we pair that with what we've talked about before, is that the people who are seen in the emergency room or urgent care, much less in a longer term stay, like a relatively brief inpatient psychiatric hospitalization, or even residential treatment or partial hospitalization, once they're discharged, they're at highest risk for killing themselves in the month to 3 months after they're discharged. So we have a very limited, pathology-oriented, non-person-centered assessment, and we have a minimal referral. When aftercare, remember that slide earlier, that one of the main ways to prevent future suicidality is aftercare. Good follow-up. So I think any questions about the problems that I've mentioned? Does that seem a reasonable summary of some of the deficits of our approach? Good. Okay. So safety planning was developed not that long ago, right? To counter all these issues. And so it's deliberately collaborative. It's deliberately transparent and co-created. By transparent, what I mean is everything we write down, they know about and they see and they own it. We do nothing in secret behind their back. Everything is guided by them, not by us. We scaffold as opposed to create dependency on them. We're not their foundation. We're their coach, their mentor, their support. When we brainstorm, we push them to come up with alternatives. We don't supply them to them. We don't give them a list that's generated by what a lot of people do. We don't give them a handout. We just give them some suggestions and build on them. We actively explore what they're motivated to do, what they will follow through with, the obstacles and the barriers that they foresee, and help them develop alternatives so that they can do the exact same things that they hope for in ways that are immediately accessible to them. So a funny kind of thing for this is we want to make coping skills as easily accessible as possible and limit access as much as possible to something that's self-harmful. Well, I guess that makes sense if we're trying to prevent self-harm, right? That we enhance the access to good stuff and we try and create all sorts of barriers and limit access to bad and self-destructive stuff. That's basically safety planning. So we have this very well thought out scheme where we start with warning signs. And like we've talked about earlier, we start with warning signs because warning signs by definition are not when the crisis is at its peak. It's more when people feel compromised, depleted, worn down, or understanding, even in a mild way, that they're coping is less than. We've all experienced this when we're starting to burn out, when we're feeling overwhelmed. We don't wait into our wits' end and we feel like jumping off a cliff or quitting our jobs in the moment or saying something untoward to somebody that we care about, whether it's somebody that we work with professionally or a loved one. We hope that we catch it early and realize that when we're not sleeping well, when we're more irritable and angry, when we're more withdrawn, when we can't focus, all the things that are personal to us, when we don't practice our spirituality, when people reach out to us and say, Avi, you're not your typical self, and we dismiss it and ignore it and lose touch with those people because we don't want to hear it, right? If we listen to that, and then we filled ourselves with the possibility, the hope that small little steps can lead to changes where if something really bad happens to us, we will cope better. We'll be at least at our normal sense, if not even at our best, as opposed to at our worst, and be overcome. That's why we recognize warning signs first, and that's totally coming from them. It's not that we supply them a list of risk factors. Okay? That's, again, part of our assessment, our risk assessment, is we overwhelm people with all sorts of risk factors and ask all sorts of questions. We ask nothing about protective factors or reasons for living, nothing, right? So how are we engendering hope, right? When all we're doing is spending 10 minutes talking about how awful things have been. So the next step is internal coping strategies, because again, indirectly, what we're giving the message is, you have the capacity to do something totally on your own. You don't need to depend on the kindness of strangers or on the kindness of professionals. You can do it. It's not all you can do, and all that you can do may not be enough, but it's where you start. Start with what you have. Start with what's readily accessible, meaningful to you. Then look to others. First, look to others just for simple, easy connection, for support for things like going out in nature, walking your dog, playing a game, talking about music, listening to music, dancing to music, remembering song lyrics, all those kinds of things that are amplified when you do it with somebody else. It's why a lot of times support groups work in recovery, because when you announce to other people that you intend to recover and reduce your harm, it amplifies the message that you're giving to yourself. And then there's the social pressure, like, well, I told all these people, so on some level, I'm holding myself accountable to them too. I'm having an audience for support as opposed to a cheering section for my decline in self-harm. Going to seeking safety, that's a big part of seeking safety, is how do you know who's safe and how do you know who's going to maximize your self-harm? Who do you turn to for help and support? How do you ask for help in the first place? So then the next step would be, you might want counsel, guidance, advice from somebody. So Patricia is a wise person. She knows my friends that I'm having difficulty with. She can have me take a step back from when I personalize stuff. She can help me problem solve. So that's different from saying, let's go and have some coffee and just have some fun, right? I'm not asking her to be a counselor. I'm just asking her to be a wise sounding board, which is different, to actively listen. And it might be that she says, you know, Avi, the kinds of things you're describing about, maybe you need to see a therapist about, or there's a drop-in center, or there's a support group that might be of help to you. Okay. Then after doing all those steps, what I can do on my own with my friends who can provide advice and counsel, some of what my friends can do maybe is, Patricia would say, like, you know, if you're uncomfortable, I'll go with you to the crisis center. I'll sit in the waiting room and we can debrief when you get out, okay? Or if you're hesitant to make the phone call, I'll sit there with you and, you know, we can chat about it. You can put them on hold and we can just talk about it, right? So they can, the natural supports, right, can also help ease the way, give you the handoff into the professional supports. And then professional supports, like I said, need to be extensively case managed, and we have to give them a spectrum, all the way from hotlines and warm lines and text lines to drop-in centers and crisis intervention and urgent care, to therapists who are accepting of and trained in how to deal with suicidality. Unfortunately, especially in private practice, there's a lot of people who say, I'm not going to touch suicide at all. This is even true. This isn't like anecdotes or gossip. Doing this work for so long and training so many and supervising so many and having a lot of institutional administrative experience in institutions, I know that a lot of people in private practice say, for somebody who they might have seen individually weekly for 3 or 4 years, suddenly suicidality emerges. Nope, I don't deal with people in crisis. I don't deal with people who need to be in the hospital. Go elsewhere, which is a horrific message. It's like, my analogy to this is like a cardiologist who says, you're having a heart attack? I don't want to have anything to do with you, right? Doesn't make a lot of sense, but that's sort of what we do. We also have agencies that say on paper that they offer crisis intervention, and the waiting list for crisis intervention is 8 months. How is that crisis intervention, right? So we have to be careful when we make referrals. I also know of people who haven't checked the phone number in 3 or 4 years. The agency's shut down. The person's no longer accepting anybody new in their practice, and on and on. So we want to have referrals that work, and we want to give people lots of alternatives. If therapist A isn't available, what about therapist B and C? And one tip that I might have mentioned to you is that the New Mexico Crisis Access Line, NMCAL, NMCAL, not only offers hotlines and text lines and warm lines statewide for people in crisis, and not just suicidal crisis, but any kind of risky crisis behavior. There are also all the agencies, and again, I might have mentioned this before, that are paid by Medicaid for behavioral health services are registered in a database that New Mexico Crisis Access Line maintains. So you can say, I have somebody who lives in Lordsburg. I have somebody who lives in Grants, and I don't know of any referrals there. They'll look it up. Okay, so that's another access for you. And when we institute nationally the 988 number for crisis for mental health, like the 911 in general, it'll be specific to behavioral health. That database will be linked to all the crisis centers in different aspects of our state. And one suggestion, I might have again mentioned this to you before, if you call and NMCAL says, I don't have anything within a 60-mile radius, say, could you make a note of that when you report back to DOH and BHSD so they can realize that this is an area of need. So when they get additional funding for developing resources, this is a target area, okay? It's a way that we can advocate publicly, right, for services. And there's funding, by the way, with the 988 to expand crisis services nationwide. So collaboration, co-creation is essential. Safety planning does not work if all you do is give them this template and say, here's an example of coping skills. Here's an example of the kinds of things you can do with other people. Here's the National Suicide Prevention Hotline. Here's the number for NMCAL. Goodbye. That's all you do. It doesn't help. It's not personal. And basically what you have to think of is, like I alluded to before, every time we meet somebody, we should offer them something. We should intervene. But a big part of it is when we're doing safety planning in this kind of way, we're saying, this is what therapy looks like, is that we're strength-based, we're respectful, we promote your agency as opposed to promote your dependency. You're the expert on yourself. You're teaching us who you are. We're focusing on you as a living human being. You're a human being, not a disorder. A person is not a disorder. or a diagnostic label. A person is a person, and we're honoring them. And also, when we go through barriers and obstacles in brainstorming, we're saying, one size doesn't fit all. You tell me what speaks to you. Be honest with yourself and with me. If none of this works, let's figure out what will. I'm optimistic, I'm persistent. So you're laying the groundwork. If they don't see you ever again, you're saying, this is what this kind of relationship looks like. And this is the kind of relationship that will help you in friends and in family as well. People who really listen, people who listen to you, people who speak to your strengths, your values, your beliefs, your motivations, your experience, and honor them. So the person, instead of feeling down, and the person is dealing with somebody who views themselves as an authority, who's directive and prescriptive, they feel that they have a buddy, a partner, a coach, a mentor, a support. So they're not left alone to struggle, but they can rely primarily on themselves. And they know that when they speak truthfully and honestly about what's going on with them, the other person will listen. And again, the other person won't be turned off. Remember, 94% of people, if they knew that somebody was suicidal, would want to help. They want to help. That's an important, critical message. It's flexible. Again, the way that we typically define illness of any nature, right, or pathology of any nature, is that something happens and we can't cope with it. So what does coping mean? Adapting, being flexible. So how can we have an approach that's rigid and inflexible and that it works? So any approach, I would suggest this, that any approach that you do, right, it's trial and error. And we rely primarily on the feedback that they give us. No, this doesn't work. No, I know I'm not going to do that, right? So if we say the only thing that's going to be helpful to you, God forbid that we would say such a thing, but we would say, we want you to commit to intensive outpatient therapy, 8 hours a day, 5 days a week for the next month. That's the only thing that's going to help you. And this, I can't possibly do that. I can't afford to do it financially. I don't know how I'm going to get there. And I need to do something different. If we don't listen to that, how are we being helpful in any kind of way? It also helps us understand about what it means to be truly collaborative and cooperative, right? And again, I do each training, I do 6 times a week, so I can't remember which group I said what to, but we've talked about certain language that's really important. We don't want to talk about committing suicide, for instance, because we commit crimes and we commit people to hospitals. We don't talk about triggers. You notice I'll say activating events or precipitating events or the stuff that happens or whatever, because the main risk is encouraging people to think about guns and triggers all the time. So we try not to use that language. But another whole group of language that we often use, all healthcare providers, not just behavioral health, actually more medical, physical healthcare do it more than we do, is non-compliant and resistant, manipulative and attention-seeking. Why is that a problem? Well, if we say that somebody is resistant or non-compliant, what does that mean? What are we saying to them about our relationship? If I'm saying to any of you, you're resisting me, you're not complying with me, what am I saying? Type it in the chat. Tell me what you think I'm saying to you. Do what I say. Right. What else? I am the expert. Yes. What else am I saying? You don't make an effort. Yes. Excellent. What else? You're all right on target. What am I saying about them? I'll give you one more idea, okay? If something goes wrong, if something doesn't work, and I say to somebody, well, it doesn't work because you're non-compliant, what am I saying? You don't make an effort, you're not caring. This is your fault. Exactly. What I'm saying is, I'm saying that, and think about this, hopeless, helpless, worthless people. And what we're saying is, you're hopeless and helpless and worthless. And if something doesn't work, instead of saying like, I wasn't imaginative enough or flexible enough to figure things out with you, we couldn't come up with things that don't work for you and find something different. Think out of the box, do something different. I'm blaming it on you. Again, a strange parallel, but think about medication. What if you walked into my office and no matter what your problem was, I gave Zoloft to everybody? Would that make any sense? Much less that if you had typical side effects of Zoloft, I'm saying you're not taking it right, as opposed to saying that's the property of Zoloft, right? And we know that whenever we do medication, it's an educated guess, and we come up with all sorts of alternatives. So if it's an antidepressant, there are dozens to choose from, right? We don't know what the starting dose is going to be for that particular person. We do what's populations in general. We know in general how long it might take to work. We know in general about the side effects, but we don't know for that particular person. So we flex. We have to do the same thing in our therapeutic interventions. So for all sorts of reasons, if we have that mindset, it leads us totally astray. We're inflexible, rigid, condemnatory, and expert-driven. We're not collaborative. We're not strength-based. So the language doesn't also reinforce them, it reinforces us, right? So that's another way in which, and one more guideline about being transparent. If you're hesitant to write something in the medical records because you're fearful that the patient might read it or even your colleagues might read it, then that's telling you that you shouldn't be writing it, right? And I've seen that all the time, that people are terrified that they're going to see their notes because they say all sorts of things that they shouldn't be saying and shouldn't be documenting. Okay. That tells you you're not being honest and truthful and transparent and collaborative, much less strength-based. Okay, so we all know about the scheme of safety planning. Here's the template. Again, you have the PDF of this, and you can see why keeping the environment safe, ensuring medications are locked up, sharps, guns removed, etc., is towards the end for all the reasons that we talked about. Now, again, if all I did was give this form to people, that is not safety planning. But that's often what we do. And also, we focus on charting things in Power Chart more than our conversation with people. And it's, again, my analogy to that is informed consent. When all of us have been in that situation on the receiving end, right, where we get 5 pages in small print and we have 5 seconds to review it, there's no chance to absorb any information from that. And there's certainly no consent, right? It's like, one of my favorite examples is when you listen to drug commercials on TV, and they spend all this time with beautiful music and beautiful people talking about all the benefits. And then they have somebody saying, so rapidly, you can't possibly distinguish this in 10 milliseconds, like 700 words about your head is going to explode, your kidneys are going to burst, and all this. That is not informed consent. But this is what we do sometimes when we do these initiatives. So safety planning has to be in this conversation that we're having now. Okay. I hope I've sold you on that. So the warning signs I've emphasized already. Now we're going to get into the nitty-gritty of reducing access to lethal means. Okay. And here's the key factor that I put in italics. A key component of the safety plan involves collaboratively identifying ways to secure or limit access. Notice that, a key component of safety planning. So just like I said, safety planning just delivered as a handout and a fixed and inflexible guideline is not at all helpful. Reducing access to lethal means counseling results in a trivial reduction in suicidality and a trivial reduction in hopelessness and depression, and the promotion of aftercare. Done well, safety planning, incorporating access to lethal means counseling. We talked about this before, but I love these studies because they show us how incredibly effective this is when done correctly. 20 to 30 minutes of safety planning that must and does incorporate lethal means counseling enhances aftercare by more than doubling the chances that they'll follow up, sometimes tripling. It not only statistically significantly, but personally significantly reduces suicide attempts and massively reduces suicides. It also reduces substance misuse and abuse, hopelessness, depression, social isolation on a 1 month, a 3 month, and a 6 month follow-up. So it's remarkably effective when done correctly. Okay. So generally, clinicians should ask patients which means they would consider using during a suicide crisis and to any potential lethal means in the environment. Remember the Columbia screen? We asked that as part of the 6 questions. When they're starting to say, is there any way that you thought about doing it, right? So we've moved from contemplation to preparation. We say, what have you thought about? What kind of method have you thought about? We don't give them a coach and say, how about pills? How about, right? But ask to see what they generate and say, have you thought when you might do that? Where you might do that? How you might have access to that? So we're already laying the groundwork for that again. So we revisit that with reducing access to lethal means. Depending on the nature of the suicidality and the nature of the method, we handle this restriction differently. With low lethality, we put them in charge. With highly lethal means, we ask them to involve a support. Now, all this information that I'm telling you is part of the safety planning and part of the preamble to lethal means counseling. Why suicide is preventable, how it's preventable, how suicidality is brief, it's context related, it's reactive for most people, and that if in the moment a gun that's loaded is not at your fingertips, if in the moment you can't go off to a remote area and hang yourself and not be found for hours or days, so you'll be discovered and your attempt will be interrupted before you die because you're supervised, because you set in a support system. So to say, Gail, if you don't hear from me like you typically do, you know, I'd appreciate you giving me a call just to check in to make sure I'm okay. So I'm not left unsupervised because we can't restrict all ropes and ligatures, right? But we can take away car keys from people if we need to. So if we can do that, we have this window of opportunity to prevent death. And we know that people whose attempt is interrupted or aborted or delayed will then feel less suicidal relatively soon thereafter and be motivated to have suicidality-specific therapies and interventions, including safety planning, which will minimize suicidality in the future. So we can prevent suicide and hopefully prevent future suicidality. Does that all make sense? So the rationale is, how do we bring this up? So we say that, from what you've told me, and I'm again drawing on that most of the people that I see and that I work with and that I supervise are people who see children, adolescents, and young adults and their families. I also see a lot of people and supervise a lot of people who deal with that reverse generation thing, the sandwich generation, when the elderly are failing and becoming demented, have paranoid, are dependent. And, this is a tangent, but it's important as far as talking about risky behavior. Elder abuse is much more common than we think about. Much more common. We typically talk about child abuse. We even talk about domestic violence, but elder abuse is extraordinarily common. Not just physical abuse, but robbing people of their finances, diminishing any kind of possibility of them getting adequate psychosocial support, medical support for their health. So we have to be really careful about placing elderly people at risk too, right? So there's a lot of ways to intervene. But we give them this rationale to say, like, so what you're talking about is, when you were laid off from work, or when your best friend was murdered, or whatever the event happened, you really plummeted. You knew that looking back on that, now you feel lucky that there wasn't a gun right there, because you would have died. You would have used the gun instead of taking a few Tylenol, instead of cutting your wrist superficially where it didn't hurt you, right? Instead of calling somebody in your support line or in your support group or in your natural helpers group in high school or whatever, and saying, I'm really feeling really blue, I'm feeling really down, can I just talk with you? Can you come over? Can we just go for a walk? I don't want to do something. That if in that moment you had a loaded gun, you might have used it and you might not be around now. Most people will say, oh, you're right. You're right. I don't want that handy. That's not wise for me. That's not good. And anybody who's truly supporting and caring and wants to keep that person safe will say, that makes sense. And again, we're not talking about gun control. We're not talking about gun restriction. We're talking about safety, keeping a loved person safe. Okay. So again, we give them all this information. And there's videos, by the way, of that Golden Gate Bridge study. And one of the people who survived it, I have a link to that in the back, became a suicide prevention specialist and talks about their own experiences. So again, we give them these statistics about guns being 95% lethal, suffocation 70%, falls from a great height 31%. We have volunteers who go to, in Taos, to the overpass, who go to the Golden Gate Bridge, who look at people who look like they're leaning over the edge, that they look like, and then just talk with them. And a lot of them are survivors of attempts by that fall. That's one way we prevent it. Poisoning and overdose, 2% or less lethal. We spent years and years always talking about overdose, but the risk is far greater for hanging and for guns and for falls. Again, if the highly lethal means aren't available, delay the attempt, use the less lethal means, they can get help and they don't die. So now to look at CALM, counseling on access to lethal means. I'm just going to give you the overview of it, what you do, okay? You talk about the scope of the problem with them, what we've just talked about how guns work, how young children often think that guns are toys and can't make the distinction. How you negotiate means restriction, gun safety in that particular environment, household, with that particular person. An assessment of what's available to them. And then you role play, like you often do in training. So you're knowledgeable about suicide facts and suicide prevention. You help identify people who could benefit, learn about the results of lethal means restriction, which I've talked to you about, how to work with people at risk to reduce access, how to inquire about the accessibility of lethal means, and suggesting safe storage. A lot of communities, the police actually will volunteer to go to a home and do a survey, and if the family wants them to, will safely store the guns outside of the home, or teach the family how to store the ammunition separate from the guns, or look at firearms where the way of firing the gun is owner specific. So somebody else can't use that gun to kill themselves. There's all sorts of ways of dealing with that. Safe storage. And again, safe, 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 we're talking about their desire. We're not talking about what guns mean and our personal feelings about guns and etc. The other part of information, by the way, that's really important is like with COVID, firearm purchases went sky high. The majority of those guns, when they were used and killed someone, were used in suicides, not homicides. The rate of suicides during COVID using guns was 3 to 4 times greater than the rate of homicides. So we hear about, mass shootings, and we focus on that. That's the tip of the iceberg of all the suicides that are there. So CALM is anti-suicide, not anti-gun. CALM is anti-suicide, not anti-drug. It's a harm reduction approach. It's not a sobriety restriction only approach. It's specific. It's part of suicide prevention. It's not the only component of suicide prevention. It's not risk assessment at all. It's part of safety planning for all at risk of harm to self and others. It can prevent homicide as well as suicide. So we express our concern, ask if there's a plan, ask us, and then take specific steps to remove or reduce firearms. For low lethality, again, we involve them. Things like all expired prescription drugs, get rid of them. No hoarding of pain pills and opioids. Limited prescriptions of drugs that in overdose can be dangerous. If a small amount of pills can be lethal, use another drug that's less lethal in overdose. Locking things up. If you're uncertain about this, you as a therapist or they as a family member call poison control. Find out about the lethality. Find out how to safely dispose. A lot of pharmacies have programs where you can drop off controlled substances and they'll dispose of them for you. Locking up firearms, locking up ammunition separate from the firearms, locking up sharps, other potentially dangerous items. And those of you who work on inpatient psychiatry, you know that it's impossible to make things suicide-proof, but we do our best. We've had people who've made life-threatening attempts on wards. Sometimes they've killed themselves on wards or in emergency rooms. So it's not perfect, but we know certainly that if we can minimize loaded guns being handed, we do a lot to prevent that. And why supervision is critical, I've sort of belabored that. And then looking at, when we're finishing the safety plan, the likelihood of the person using the safety plan and making revisions. We're always looking for feedback. We're always asking them to be really creative about looking at barriers and obstacles and what they're motivated to do and what they're not. So they can give us the information to help them create new options, new possibilities. And always say that anything that comes up, I'm here to help you revise it. And what seems to work now may not work next week. Let's revisit that. So you're setting the stage again that safety planning is an ongoing, flexible, adaptive approach, and that you are invested in continuing that conversation. You are the colleagues that follow you. So the best safety plan is comprised of interventions based on the likelihood of success and their willingness to carry it out. And briefly, you all know this. I know that all of you are steeped in motivational interviewing here at UNM, but we're communicating respect for that person, their autonomy, value cards, right, as part of motivational interviewing. We're drawing out their ideas, their motivations, and dealing with the parts of them that lean towards reasons for living and how those parts can grow and flourish, and the parts that lean towards reasons for dying can be reduced. You all know about change talk, supporting commitment to take action, looking at motivation, taking the steps needed to make small changes lead to larger ones. Same thing with solution focus. People do really want to change. They have what they need to solve their problems. All they need is coaching, support, creativity, trial and error, the ability to set modest, concrete, reachable, achievable goals that they control, not that depends on the goodwill of other people or the bad will of other people. Focus on what they're already doing that they want to continue. Focus about the times that the problem could have happened because of a bad circumstance, but they did something different and it worked. So our curiosity is much more about the times when the problem was less than when the problem was at its worst, which is the opposite of how we typically take a history. Right? If it ain't broke, don't fix it. Do less of what doesn't work and do more of what does. So that's safety planning sort of in a nutshell. Here's the summary of good care for suicidal patients. And again, you'll get the PDF. Informed consent, thorough assessment, like we talked about, really good referral process and disposition planning, and empirically supported suicide-specific treatment plans and treatments, including safety planning, right? As well as the appropriate use of medication and hospitalization. And notice this quote, the explicit development of coping techniques that may render suicidal coping obsolete over time. That's our goal. Consult with other people. We encourage them to brainstorm. We should brainstorm with each other. We all learn from each other's experiences. We're aiming for a life worth living and instilling hope. So we'll start our discussion of seeking safety and continue our discussion of safety planning next week. I hope you all join me. Here is the QR code for your smartphones. Anthony just posted the link, the same link in the chat room, so you can access it either way. That gets you the survey to your CEs or your certificates, as well as making sure you get the PDF of this PowerPoint. It's been wonderful to be with you for the past 4 weeks. I hope you'll join me for the next 5. Be well, everybody, and thanks for keeping New Mexican safe. Really appreciate you.